Hey, good afternoon. Welcome once again to our webinar series entitled Frontline Report, Autoimmune Liver Disease and the Pandemic. This series of webinars are made available via collaboration between the Autoimmune Hepatitis Association and the Center for Autoimmune Liver Disease and Cincinnati Children's Hospital. My name is Craig Lammert. I'm the Executive Director for the Autoimmune Hepatitis Association and an adult hepatologist at Indiana University. I'm once again excited to help host this third webinar in our series entitled Doctors in a Hot Zone. Quickly, a disclosure from the AIHA. This webinar series does not replace your primary physician, gastroenterologist, or hepatologist. We cannot diagnose, treat, or manage symptoms associated with autoimmune hepatitis. In this webinar, we are lucky to have insight and commentary about the coronavirus pandemic from two very strong and brilliant women, Dr. Christina Chaco and Dr. Jennifer Vittorio. We've been looking forward to hearing their perspective of the pandemic, not only as doctors, but specifically as hepatologists in the adult and pediatric world working in New York. Before we spend time with our special guests, Erin Anderson, the AIHA's Director of Programs and Development, will lead our autoimmune liver disease specific COVID-19 pandemic update. Erin.
Thank you, Dr. Lammert. We are so fortunate to have Dr. Aaron Ermel back with us. Dr. Ermel is an assistant professor at Indiana University School of Medicine and is also an infectious disease expert. He's been a presenter at all our webinars so far, and we really appreciate his commitment to updating us on the pandemic. Welcome back, Dr. Ermel.
Thank you.
Testing has been in the news a lot lately. Before we get into some more specific questions, can you give us a basic overview of the nasal swab test that detects whether someone has COVID-19?
Yeah, so this method basically, it's what we've been using since the epidemic started, and we use this a lot in many other respiratory viruses, so that's kind of how we knew how to test, I guess, initially. And so basically a swab is inserted into the nose, and one of the best sites to do so, which is also the most uncomfortable way to do it, is actually going through the nose and to the back of the nose and actually to the very, almost to the top of the throat. And so you scrape a lot of cells along that area that are potentially infected with the virus. And from there, we extract the genetic material of the virus from that sample. And then we use a machine to kind of amplify that so we can detect it. And then that's tells us whether the virus is there or not.
We've been reading reports that false negative rates for the nasal swab tests can be as high as 40 to 50%. Can you explain why this is and maybe whether the accuracy of these tests are suffering because of how quickly they've been developed?
Yeah, so there's a lot that goes into developing these tests, and I've been involved in other diagnostic development studies, and usually there's a couple of years worth of work that leads up to getting a test FDA approved. But we can't do that in a pandemic situation. So developers have put together a test that works reasonably well, put it through tests that they can do in their lab, and then they send it out to other diagnostic labs to be able to be used. And that's where the FDA is giving these emergency use authorizations, saying, we don't have a lot of data, it looks like it works okay, try and use it yourself. And then they'll actually review that data after a couple of months of use to see if it's even worth keeping on the market. The reason that we run into issues with the false negativity is there's issues with the sampling process. So the nasopharyngeal swabs, what I just described, are probably the best way to collect for it, but it's not perfect. There are ways you can miss it. It's just a sampling issue. The second is the dynamics of the virus itself. So as you proceed through infection, the amount of virus that's actually in the nasopharyngeal space decreases over time. And if you're getting worse, actually increases in the lungs as it decreases in the nasopharynx. So there can actually just be amounts of the level of virus that's there. And then the other problem with when we're calculating these numbers, when you say false negative, that means that you have a test that works so well that it is what we call our gold standard by which we will compare all other tests, and we don't have that in this case. So sometimes it's a little hard to interpret these false negative rates because we don't know how the test actually performs when we compare it to other tests because they're all so new. Usually when we're establishing how well a test works, we already know what the gold standard, what we've always been using test is, and so then trying to compare that to a new test is the usual process, but in a pandemic situation, we just don't have that.
That makes sense. Home tests have also been in the news quite a bit lately. How good are these tests, and will everyone eventually be able to test at home if they're sick?
Yeah, so it depends on the type of test. So the ones I'm talking about, the nasopharyngeal, are PCR based, or you'll even hear RT-PCR based tests that look for the genetic material. It's going to be really hard to implement that at home. There's a couple of tests that use a particular method that you might be able to do at home. It's relatively quick and uses very few materials. And those seem to function relatively well. They actually have not been compared to our standard. The other, where they're going to maybe start implementing antibody-based testing, they've already tried to develop a couple tests that you could do that at home. Some of these actually use a piece of paper. Believe it or not, it's actually, you'll hear the term lateral flow. So we actually have these in other types of diseases, like trying to detect malaria or HIV. So we're extrapolating from other diseases and trying to implement it in the pandemic. Those, I mean, there are some issues with those tests. They could eventually be very good. They need time to be developed and perfected, if you will. Right now, I think they're still very early stage, and we're struggling with how specific they are. Is basically, I think, the big problem with them. But you'll see those coming down the road. But I don't know really if home-based testing is what we're going to need for this disease. So then there's the other facet to that, which is the need for such testing. So.
We're hearing about some patients receiving a positive test for COVID-19, recovering, and then testing positive again. Why is this?
Yeah, so some of this has to get back to the sampling method. So how well, can we detect the test or the virus when we actually sample for it? And the other is it's part of maybe the dynamics of the virus. So since it's so brand new, we don't actually know, kind of what it goes through phases during an infection. And so does it have, really, really high amounts of the virus in the beginning, and then it dips down a little bit as your body starts to get under control? And then is there another period where maybe the body relaxes that control and a little bit of the virus comes back, we're able to detect it because the person might actually look better, but we're still able to detect a little bit of the virus. And there's certain states that we know of, and I think we've discussed this on the webinar before, that, if you're on immunosuppressants, some people are actually not having severe disease, but they're shedding virus for longer. So these are the other people we may see very low amounts of the virus being shed, and your test will be intermittently positive for a longer period of time because of those immunosuppressants. So this doesn't, I think it's surprising in one sense, because we think people should just get over, but it may, since we've not, this is one of the first epidemics that we've actually been able to follow tests like this repeatedly. In other epidemics, like even in the first SARS in 2003, we didn't quite have the same access to technology. So it'll be interesting to see what we learn about the natural history of this disease.
You mentioned antibody tests a little bit ago, and I want to return to that because they've also been getting a lot of attention in the news. What do these antibody tests actually show, and how important are they, especially as governors are starting to gradually lift the stay-at-home restrictions?
Right. So an antibody test, when you're looking at an antibody, the antibody is something that your body produced as a reaction to a pathogen. So this can be any pathogen. And so what we're really looking for, and especially is a very important infectious disease, is a measure of exposure. So this is regardless of symptoms, this is regardless of what disease you thought you had, this is actually looking at exposure. And so what we think is by the time you have certain antibodies, you've recovered from the disease, and it represents one arm of the immune system's response. So what they want to use this for is actually looking for how many people in the population were exposed, meaning that they were exposed, recovered, and that they probably have some sort of immunity. What I think a lot of people have been confused by has been the World Health Organization statement that there is no evidence right now to suggest that people couldn't be reinfected even if they have a positive antibody test. And they're correct in saying that. I think they're trying to be very conservative, so I don't want people to misinterpret that to say that we have evidence saying that people have been reinfected multiple times. It's just that we don't have, that virus hasn't been around long enough for us to really tell whether the people can be exposed again and then infected. So there's a lot of evidence right now that's starting to build where we're trying to look for that. So there's studies that we're trying to do that, but we can't even measure for we can measure for the antibodies, but we don't know what their significance are right now. So that's really what we're doing with antibodies, is looking to see who all was exposed, who could potentially safely not be worried about reinfected. But again, that's going to be some time before we realize how protective the antibodies we make really are.
So based on those recent reports from the WHO, is it important for patients to know if they currently have or have had COVID-19?
It will be important as we move and look into what the risk is of subsequent outbreaks. So that's, I think, what we're really trying to measure is that if you've got a significant amount of the population who has been exposed already, they are less likely to be susceptible to the virus. So when we look at, when people are talking about these second waves, whatever people think that may be, it's going to be dependent upon the number of people in the population who've been exposed to move out of our susceptible category into our potentially protected category. And the higher number of those recovered individuals that you get, the less likely that you'll see the large waves like we've seen initially here in traditional epidemiologic models. But like we saw, we don't know if those antibodies are really protective.
Great. I want to switch topics a little bit here and talk about household spread. If someone in a household has had COVID-19, our members are really interested in this. Recent data suggests that we can minimize household spread if adequate quarantine methods are done in the home. What are your thoughts on this?
So yeah, I mean, it's been shown, and this isn't actually like the first pandemic where we've looked at household spread and looking at quarantine efforts in the home. So in other, pandemics, it has been shown to be effective. And so I think you can have high transmission among, spousal contacts and other what we consider household contacts, which are actually defined as people in the same space for, I think, about like 8 hours or something at a time. But it is effective in trying to maybe quarantine them or trying to use that social distancing measures that you would use out in public, trying to do those at home. Now, depending on your living situation, that may be very challenging. If you're in a small studio apartment with one other person, that managing that 6 feet distance may be difficult. But trying to segregate rooms, trying to not overlap in schedules, and maintaining cleaning surfaces and things like that are probably effective in the household space.
Let's fast forward to fall 2020 and the new flu season. There could be a resurgence of COVID-19. Are we doomed?
Well, so I wouldn't say that we would be necessarily doomed, because if it is the same disease that we're dealing with now, the number of people who've been exposed already is also reduced. And then when you think about the second wave, at least my hope would be that the world would have overcome some of the challenges of testing like we've had, and a lack of supplies for PPE and other things that catch you off guard during the first pandemic, that maybe over the summer, if there's a lull, that we're able to build up that capacity, have a better understanding, and then a better plan of how to prevent further infections. I think what people are worried about is compounding what we already see, tens of thousands of deaths every year related to influenza, and then you add COVID on top of it, which is the other thing that says, well, we have a vaccine for flu. Why are vaccine rates for flu are so low? I'm hoping those will go up next fall when people are a little bit more concerned about respiratory viruses. So I don't think we're doomed. I think we would be in a different situation. It's simply because I think we'll be more prepared with our other testing methods. It's just the concern that the COVID-19 came towards the end of what we consider our traditional flu season this year. If they were to come in the fall, if we were ever a resurgence of COVID, we would be seeing the same seasonal pattern of influenza increasing with late fall into winter. And at the same time, you'd had COVID there. So they would actually fully overlap, which is, I think, the major concern people have.
Well, thank you again for being here with us today and sharing your perspective on the pandemic. We really appreciate it.
Oh, thank you for having me. Yes.
Wonderful. Now I'll hand it back to Dr. Lammer.
Thank you, Aaron and Dr. Ermel. New York has been the world's epicenter for the coronavirus for the past 6 weeks. This nationally televised and very public journey of New York has been marked by many ups and downs, such as limited supplies, outspoken healthcare workers, and political clashes, but also signs of unity and togetherness. Recently, with the flattening of the curve, the city seemed to be approaching a promising bend in the road. Yet with the challenges of safely opening up communities, like many of us, New Yorkers are feeling that we may be stuck in much of the same for some time to come. The pandemic has changed everyone, or at least their perspectives, but maybe even more so the healthcare workers that are on the front lines. It's my pleasure to introduce Dr. Christina Chaco, our first doctor working in a hot zone, and thankfully maybe less hot recently. Dr. Chaco is an assistant professor of medicine at the Albert Einstein College of Medicine in Bronx, New York. She's been on staff there at Montefiore Einstein Center for Transplantation since 2013. There she is a program director of the Transplant Hepatology Training Program. Her clinical focus ranges across many types of liver disease, but she has special focus on transplantation and autoimmune liver disease as well. So Dr. Chaco, thank you so much for joining us today.
Happy to be here.
And to get personal right off the top, I think a lot of our members are really interested in your life and how your life has changed with this pandemic, particularly being there centered in the thick of it.
So things obviously ramped up very quickly in New York. By sort of early March, things were already changing. So I was actually on our transplant service when cases started to increase in early to mid-March, and automatically, you know, everybody was on the defensive. So immediately people were like wearing masks and really just everything that we can do to kind of protect our patients, really limiting how much patient contact we were doing. But at the same time, you know, there was still full level transplant care and everything happening. I came off the service and was out for about a week when I got actually called to be on one of the COVID wards. And so since then, I haven't really been doing any inpatient liver care. I've only been doing inpatient COVID care, which basically completely changed my normal scheme of practice. I'm still teaching and working with residents, but on a field that I knew nothing about, and really most physicians didn't ever know anything about. So in some ways it's been really cool because I've been with a team of other hospitalists, other specialists, rheumatologists, cardiologists, and we kind of sit in our office, and after we didn't finish rounds, and we're all just trying to parse through the information and learn about COVID. And every day, you know, the first month was just this constant stream of learning, whether it's relearning how to deal with respiratory failure, which I've kind of always triaged to critical care and pulmonary for the past 10 years, but also just learning about this disease that we knew literally nothing about until this past month or so. So it's been kind of a whirlwind.
Yeah, no, it sounds like it, but maybe to give us a better picture, what was your life like in patient care prior to this? What was your normal day like?
So I do a mix of inpatient and outpatient, all hepatology and transplant. So usually I would, on my weeks that I'm just doing outpatient care, I would be seeing patients in the office, usually a mix of about 30% transplant patients, either waiting for transplant or post-transplant care. And then the rest of them are all general hepatology, autoimmune hepatitis, and as well as, you know, viral hepatitis and the whole mix. And then usually about 1 week every 5 or 6 weeks, I'd be on service taking care of our inpatient. We have an inpatient unit that deals with only our transplant patients. So again, patients that are sick waiting for our transplant or are post-transplant in the hospital. And so my usual day-to-day was all liver all the time. Yeah,
no, right. So how did that transition, or what did that transition look like as things appeared to start turning south for New York? How did your healthcare system kind of transition? And as doctors, you know, were you scared? Were you ready to meet the challenge?
I think I knew pretty early on in March, once things started ramping up, that I was going to get deployed. So I think mentally I knew the call was going to come weeks before the call actually came. That being said, things were changing at such a rapid rate that I literally came home one evening, went for a run, came back, checked my email, and it was like, report to this hospital, another Montefiore associated hospital, but I'd literally never been to before, had never seen this hospital before, knew it by name, never been there. Report there 8 a.m. tomorrow morning. And it's 7 p.m. the night before. And I was like, okay, well, I guess this is happening. And I'd like a little bit more information. But that was basically it. And then I was excused from all my inpatient duties. I started quickly, we'd already, before that, had already started transitioning all non-urgent outpatient patient care to a telemedicine system. So we were already sort of in the process of making that transition. And so basically, as soon as I got deployed to this, I canceled most of my visits except for patients that needed to be seen. And then those were either seen by someone who was still in the office, or I would try and do televisits when I had some free time.
Sure. And you know, I'm sure that was probably frightening, a big transition. But again, we've seen it here at our university as well. People rising to this occasion. What were you worried or nervous about, or what did you see colleagues worry about?
So I think the biggest concern, especially the first couple of weeks, was getting COVID. So I actually got lucky because I actually already had COVID before I got deployed. So I also had immunity or theoretical immunity, since we don't actually know. And so that was helpful for me, but definitely a big concern was a lot of healthcare providers. I got COVID a couple of weeks before when I'd been on the service. Multiple residents and other hospitalists, really when this infection was starting to spread throughout New York, people were getting sick and the hospitals were not allowing people to wear N95s. And so it was really common that people weren't wearing masks or weren't wearing N95s when they were encountering this. And you were starting to see higher and higher levels of patients coming in with clear symptoms of COVID, and patients, for example, gastroenterologists who were performing endoscopies weren't being permitted to use N95s. And sure enough, a week later, the entire endoscopy suite was shut down because multiple nurses and gastroenterology attendings had all developed COVID, and so they just had to shut the unit down. So in those early days, with the number of healthcare providers that were getting sick, the biggest thing that was really terrifying for everybody who was on the front line was getting it and then also bringing it back to their families. And so a lot of, I'm fortunate enough that I'd already had it. I was not worried about transmitting it to anybody else. But a lot of my coworkers were living in hotels away from their families, or they had shipped their families to go live elsewhere. One of my close friends, her husband actually runs the ER at Bellevue, and she's been out on Long Island with their 1-year-old living with her parents, and their kid hasn't seen their dad face to face in now going on 6 to 8 weeks. So it's just, I think the risk of transmitting it to your family, to your loved ones, I think has been the scariest thing. And then the other really scary thing is just dealing with a disease that we don't know all about. You know, I'm, as a hepatologist, as someone who's been doing transplant, I'm used to knowing a lot about this really small, specific thing. And that's why I went into transplant. It's why I like what I do. I feel confident. And when I don't know something, I know I don't know it. And then I have this whole team of people who have even more experience than me that I can ask. And when we were dealing with COVID, it's terrifying because we don't know anything. Everybody's learning, even that in the infectious disease team, the pulmonary critical care, we're all rapidly learning. And as the weeks went on, we were changing what we were doing, protocols of, you know, early on in respiratory failure, you would want to put patients on the ventilator right away. And now we're learning that's actually the wrong thing to do in COVID. It's not the wrong thing to do normally, but so I think the not knowing has been really hard for healthcare providers. It's hard to reassure patients. It's really hard to reassure families who can't actually be there. And so I think it really was just a challenging time for all of us to be doctors, because you feel a little bit like you're a medicine resident again, which is a hard transition when you've been doing something with relative confidence for years.
Absolutely. And just a little personal sideline, if it's not too personal, what was it like having a coronavirus infection or COVID-19?
I feel like I had a pretty mild case, so I'm gonna say my personal experience wasn't too bad. My resident that I'd been working with the prior week got sick. He notified us. Sure enough, about 48 hours after he had tested positive, I spiked a fever, was feeling just generally crummy, and fortunately at that point, this was in mid-March, Montefiore had testing for employees, and so I was able to go get tested, and then just kind of convalesced at home for a week. I think that by the time I was feeling better, the being completely quarantined in my apartment, not being able to leave at all, was probably the biggest challenge. I got so tired of sitting down that I literally was just standing and walking in place. But I think I was very lucky. I actually know a number of people who've had it and have been much sicker. And there's unfortunately, multiple hepatologists and that, people I've trained with that have had much harder courses, older folks who've ended up in the ICUs, and it was very scary. So.
Yeah, and I think that it's worth noting for our members that there was just a report yesterday from WHO and CDC that over 9,000 healthcare workers here in the U.S. have been infected, at least that we know about. So this is a significant thing, and some with severe outcomes, obviously, but again, these are our frontline workers. So you had mentioned back before you use this word service. What does service really mean? And maybe help that to understand what is your interaction with COVID patients in terms of how you connect with them, how you care for them in the hospital.
So we take care of patients on the inpatient ward. So I'm on a unit that has about 35 beds in it. I take care of about 12 to 14 patients. And so I round with a team of residents. Some are medicine residents that are still in training, and some are actually brought over from other services. I have an orthopedics resident who hasn't done general medicine in a couple of years. He's been, in the operating room. And so, but they've actually been great. And the residents have been really spectacular at stepping up and taking care of these patients and, really accepting this as our duty as doctors. So we round each morning. We usually round separately from the patients. Normally in transplant, I would go and we do bedside rounds and everything. Really, this is to minimize as much time in the COVID rooms as possible, especially for the residents, to avoid them getting sick because they're in and out a lot more than I am as the attending. And so we discuss all of the patients that are on the service, including anybody who came in within the past 24 hours, any new admissions. And then we go see each patient in the room. We have to be fully gowned up. So we wear a full kind of protective gown. We have a N95 respirator mask, which is basically something that usually we'd only used for tuberculosis patients, but because of the potential for aerosolization of the virus, we wear these N95 masks. Then we wear a regular surgical mask over it to kind of keep it clean because we're kind of conserving the N95 masks. And then we have a face shield as well, really to kind of protect as much as possible. And then we change our gloves in and out of each room. But we basically go around, we've got our little pulse ox and we go in and we see each patient, we talk to them about how they're doing that day. We really check on their oxygen status. And most of what we're doing is really seeing how well they're able to move around. A lot of these patients, interestingly, do best if they're in what we call prone, which is when they're lying on their stomach. So we try and encourage patients to either lie on their side or lie on their stomach because it really helps oxygenate the lungs better. And then we basically adjust their oxygen. We see if we can decrease it a little bit. We try and get them out of bed, see if they can walk around and really work with them that way. We have iPads that can be brought from room to room. So patients can actually FaceTime with their families in case they don't have a device with them that's allowed them to communicate. We can have the family members kind of come into the room as it is to kind of be there for that interaction. And so that I think has also been a nice thing for the patients. We have to be really, because we're always wearing all of this garb, we have to be really aware of introducing ourselves, because everyone looks the same. Every person that walks in is just a pair of eyes, and then just covered in a sheet and goggles and masks. And so we have to be very conscientious about identifying who we are, so that patients aren't just terrified all the time that these strangers in masks are coming in, especially since a lot of the patients can be older, and a lot of them come in confused when they get COVID. So they may not even know exactly where they are, what's going on, or why they're here.
Sure. Well, speaking of patients, and again, our audience is obviously very interested in liver outcomes. And again, I think we're learning more and more in that realm, as you said. And again, it's hard to keep up, but we're learning more every day. But anecdotally, can you give us any comment as a hepatologist of what you're seeing with patients with known liver disease, and how they're doing, or what challenges may come up from COVID-19?
So I haven't personally been taking care of any of our transplant patients or any of our liver patients over at the hospital that I'm at now. We actually have been collecting data, and also the University of Washington. I'm not sure if you've been following along. The University of Washington's been collecting data really since the beginning about all solid organ transplant patients, to really look at how patients are doing. It's interesting because a lot of the reaction to COVID, like the way the body reacts, is actually not directly the virus, but it's the immune response to the virus. So a lot of patients, when they get really, really sick, it's thought to be this release of what we call cytokines that cause the lungs to kind of fail in the end, and can cause high fevers. And so this is really an immune reaction. So something that patients with autoimmune hepatitis are probably all too familiar with is this hyperactive immune response. So it's interesting that actually, of our patients with liver transplants that are on some degree of immunosuppression, haven't done as poorly as we might have expected. And actually, one of the mainstays of treatment that we've been doing on a lot of patients has been steroids, to help in patients who are a bit sicker, is to really ramp down that inflammation and prevent that kind of explosion of an immune response, and that seems to be helping. So I haven't dealt too much with our decompensated cirrhotics or those, but so far I've had several autoimmune hepatitis patients, transplant patients that are all outpatients, fortunately, that are still doing well. They got COVID. They didn't feel so great for a week or two, but they're all recovering at home and didn't even actually have to be hospitalized. So I think it really varies. I think liver disease independently doesn't seem to be a major risk factor, the same way diabetes, respiratory failure, chronic respiratory illnesses obviously predispose you to doing worse. So.
Yeah, no, I think that's great. And we've highlighted some of that data from the MERS and SARS outbreaks as well. Again, maybe immunosuppression is not a bad thing.
Mm-hmm.
Again, as we learn more, hopefully we can have a little bit more of a global sense, but we've strongly advocated patients not change any of their immunosuppression.
Absolutely. Yeah, I don't think it seems to really increase their risk of having a worse outcome.
Right, which is fantastic news. Maybe kind of shifting gears a little bit as well. It doesn't sound like you've had to do much outpatient, but I'm assuming, are you still taking care of your chronic outpatient clinic patients when they call or leave messages?
Yeah, so usually in the afternoons, I kind of have 5 to 10 patients that I'm doing telephone or video visits with each afternoon, again, to try and keep up with people, because whether it's, my chronic hepatitis B or really stable patients, I don't want them to be pushed back months and months. But then certainly the sicker patients that need frequent care, we're trying to check in once a week or once every other week to really make sure that their needs are being met. It's definitely challenging, and it feels very chaotic. It makes it really hard because I don't have a routine, and I'm used to a routine, and I'm used to also having my transplant coordinator, who's kind of my partner in crime, who we work together and see all of our patients together, whether it's transplant or non-transplant. He actually was deployed to the ER the same week I was deployed to the wards. So it's been really challenging to keep up with the outpatients. Televisits are tough. The telephone's a little bit easier, but the videos, it's tough to get people on the call at the right time. It's not an efficient method of patient care. It's great that we have it. I'm really glad that we're able to keep up with things. I don't think it's the way I would want to practice medicine indefinitely.
Certainly, right.
Yeah.
And in that regard, in management of the chronic patients, a patient that's one of our members had asked this question. We've talked a little bit about this in the past, but how do we balance this waiting to get labs or diagnostics or imaging in this patient population, either autoimmune hepatitis or transplant patients? When is it safe to go back to the lab? When is it safe to wait? Any advice that you would give your own patients and how you're overcoming that challenge?
I mean, I think it's really up to whether or not I'm making active management decisions. In patients that have been stable, for example, an autoimmune hepatitis patient whose liver tests are perfectly normal, we haven't been messing with their meds at all, everything's nice and stable, I feel comfortable pushing that 3 months and saying, you know what, everything's been totally stable for 2 years, 3 years, we haven't been changing your meds, we can push the labs. In patients and same thing with patients that are post-transplant, they're 2-3 years out, everything's been fine, they're taking their meds, I'm not worried about a compliance issue or anything like that, I'm okay with pushing it. In patients who I'm making active decisions or I'm worried about, or their liver tests have been bumping around a little bit, or I've been recently adjusting their medications, I'm asking them to go to the lab, wear a mask, go in and out. In cases where we can make an appointment, try and make an appointment so that you're really minimizing interaction. But, you know, ultimately if I don't want anything bad to happen to their liver any more than I want them to get COVID. And so, you know, it's really just a matter of practicing kind of with as much caution as possible.
Absolutely, and I think that's exactly what we're doing as well. And again, it's sometimes it's a relational decision between them and their doctor as well, and
Yeah.
and knowing there are risks and benefits with each side of it. But again, hopefully this will be narrow as far as a time window, maybe longer than you'd like to think. Speaking of patients, though, have you seen how have your patients been coping with this pandemic? Have you seen anybody doing anything novel or unusual or helpful that you would recommend to other patients? And I bring it up primarily because we had a talk recently about mental health and seeing a lot of flare and things of anxiety and depression and poor sleep.
Yeah.
But maybe even taking from your book as well, what do you do to help you cope in a healthcare worker that's facing a lot of stress with the current pandemic as well?
I think I'm doing what a lot of people are doing, which is cooking a lot. I mean, I like cooking anyways, but now my freezer is literally filled with like labeled containers of 20 different types of soup because I make some and then I'm not going to eat all of it. So now I have just a stockpile of food in my freezer that I've cooked and frozen half of. And exercise has been a really big thing. So I think, you know, just kind of taking things that I enjoy and really trying to maximize the enjoyment out of that. The spring is here. The flowers are insane in New York right now. So yesterday evening I came home from work and I, you know, went for a walk in the park and enjoyed kind of how beautiful it was. And even though it wasn't how I would normally be spending my Saturday night, you just kind of have to appreciate the fact that like the world's still turning and there's still a lot of beauty out there. And so I think, you know, certainly there's been a lot of people who've been more anxious. I think that anxiety more than anything has been like the overwhelming emotion. As a not particularly anxious person myself, I've also felt overwhelming anxiety. So, you know, I think that really connecting with people and sharing that, and I think it's been really helpful for me to kind of commiserate with my other, you know, coworkers that are right there with us, that whenever we have frustrations, we have someone that we're able to vent about whatever is going on, whether it's in the hospital, whether it's personally, whether it's about, you know, the management of this whole situation, being able to talk to people about, you know, whether it's a professional person or just friends and family. I think it's been really helpful to kind of continue to make sure you're having those connections.
Yeah, no, I think those are great words of advice. And speaking of things of beauty and positive things, any positive reflections throughout this whole crisis? Have you seen anybody step up or anything that's noteworthy that you share among friends and family?
Yeah, I mean, I think really just all the healthcare workers that have stepped up, you know, that there really has not been anybody who's like, I don't want to be here. I'm being forced to be here. No one, not a single person I've encountered. And I actually have had multiple friends. I have a friend, one of my former co-fellows who's out in LA, who's she wanted to come back to New York to help. I have a friend who was a pediatrician in the UK, who now works as a researcher, hasn't had a license and practiced medicine in 7 years. And she's like, I want to help. If there's anything I can do, if I can be basically a junior doctor, like act as an intern, she's like, I just want to help. So she signed up when Cuomo was contacting anybody who is a licensed provider. She's licensed in the UK. It's really been amazing to me how many people are just like, especially people who went into medicine who already felt that calling. It's kind of been a no questions asked. I want to be here to help. People obviously have expectations. They want to be taken care of. They want protective equipment. I think that the lack of PPE was terrifying, but I don't think that ever called into question whether or not people really wanted to be there, wanted to help. And I think it's been a pretty amazing thing. I will say also, I love New York City. I mean, like this city, just like, I'm sure people outside of New York have heard that at 7 p.m. they basically cheer for all the first responders, for all the frontline workers. And it literally brings tears to my eyes every single time. I'll be like coming home from a run and the cheering starts and I know it's 7 and I literally just my tears start welling up because it's just like a really lovely thing that, even though people are all trapped in their apartments and going stir crazy and things are really tough, New York just kind of shows the love. And I think that's been really great.
Yeah, no, that sounds amazing. And our final question, Dr. Chaco, I read something that said that many Americans may not remember this pandemic, yet maybe those in the healthcare field or those that have had some major impact, either financially, socially, or lost someone will remember it better. What will you remember 30 years from now about this time?
What will I feel like I'm going to remember everything. Maybe it's just really fresh right now. Yeah, I mean, I think that it's been such a challenge as, whether it's the quarantine in itself, just being isolated from my friends and family, not being able to travel and do all of the things, not being able to go to restaurants, I mean, it's been a huge shift and it's hard to even look forward to what our life is going to be like in 3 months and 6 months and a year. The idea of going to a crowded restaurant or bar seems unfathomable to me at this moment, I think that what I'm ultimately going to remember is the kind of camaraderie I think that all of us really shared and in kind of stepping up and going to fight for other patients, to really make sure people could try and come out of this, that we're giving everybody the best shot we could. So I think that the way that everybody has stuck together and really pushed through it has really been impressive. And I think that's going to be the biggest thing that I remember.
Oh, that's great. It definitely sounds memorable. And I just want to tell you from myself and also on behalf of the AIHA, many don't know, but I went to residency with Dr. Chaco and I look up to her much like a sister. She's the kind of lady that I see every year and it's like we've never missed a beat. And I know I've missed seeing her in the past liver meetings, but from me to you, I just want to tell you thank you for all you do. And we really appreciate you taking care of patients and stepping up to the plate. So thank you again, Dr. Chaco.
My pleasure.
I want to introduce Dr. Amy Taylor, who will host our next guest. Dr. Taylor is an assistant professor of pediatrics at Cincinnati Children's Hospital in Cincinnati, Ohio. She's a pediatric hepatologist and part of the Center for Autoimmune Liver Disease team. Thank you, Dr. Taylor.
All right, thank you, Dr. Lambert. I'm so glad to be talking with Dr. Jennifer Vittorio today. She's an assistant professor of pediatrics specializing in pediatric hepatology at Columbia University Medical Center and New York Presbyterian Morgan Stanley Children's Hospital in New York City. She is also the founder and director of the Platinum Program, which focuses on transitioning young adults from a pediatric to adult practice. Thank you so much for being with us today. Has your role as a hepatologist changed in the past few months?
Hey, Amy, I just wanted to really thank you guys first and foremost for inviting me here today to kind of share my experiences. I think your first question is a very interesting one because I think for all of us, not only in hepatology, our roles as healthcare providers have certainly changed pretty dramatically over the last, month or so, and we're having to, adapt to our current situation and find new ways to offer, care to our patients, to our staff, right? So I think the answer to that is certainly yes. I think we've had to, make sure that we're practicing smart medicine right now. And the way we've gotten doing that mostly is through the use of like telemedicine and doing virtual visits to try and keep in touch with a lot of our patients and sort of limiting the amount of time that we have to see them here on campus unless it's absolutely necessary.
No, that's really interesting. Now, I know that you are trained as both a pediatrician and an adult medicine practitioner. Can you share your perspective as a physician trained in both of these?
Sure, absolutely. So my current practice is actually mostly limited to just pediatric patients at this point in time. I think having trained in, both disciplines, I'm still very much involved in the med-peds community. And so that's allowed me to sort of reach out to a lot of my colleagues at different institutions and to find out, what roles that they're, taking on currently, how they're caring for patients, what their approach to medicine has been. I think even, here at Columbia, we've always had a very close relationship with our adult colleagues. I think we're trying to learn from them as much as possible, not only with how they've sort of adapted and changed their policies, what has the approach been to a lot of patients who are diagnosed with COVID, both inpatient, outpatient. I think that it's, for me, it's been really interesting or sort of challenging because as you can imagine here in New York, things have changed pretty dramatically and there has been a lot of talk about redeployment. One thing that has happened is within our institution, most of our other pediatric programs have closed. And so the Morgan Stanley Children's Hospital is now the sole pediatric hospital in our healthcare system. And so we have transferred a lot of patients from outside institutions here to our facility. Because of that, I think that a lot of our pediatric providers have sort of been a little bit slower to be redeployed. For me personally, it's been a little bit of a struggle, wanting to kind of step up and help out on the adult side if and when needed, but also sort of those feelings of not wanting to abandon our current patients and, where can I best help and where can I best serve? So that's, I think for me, been the sort of most interesting, I don't know if the struggle is the right word, but, just in our what's going on right now.
That's very understandable, and especially I know that you're currently, taking care of patients on the inpatient service right now, as we're discussing this. I think, so have you been involved in the care of patients diagnosed with COVID-19?
So, I will say that, we've seen fewer cases of COVID-19, at least in patients, in the pediatric population, when we compare ourselves to a lot of our adult colleagues, where it just seems that most people that are admitted to the adult side right now are, at least carry this as one of their diagnoses. We have taken care of a few COVID patients on our pediatric hepatology service. Those have been mostly transplant patients or patients undergoing transplant evaluation at this point in time. We have not yet seen any patients with autoimmune hepatitis, at least requiring inpatient admission. I think the biggest case that we had was an infant who had undergone liver transplantation back in early March, around the time that COVID was really starting to hit New York pretty hard. And she did develop the disease. She did develop a pretty significant hepatitis. Maybe, because she was on immunosuppression, I can comment on that a little bit or not. She did have some respiratory symptoms, but I think really more remarkable for her was the GI manifestations of the disease, the hepatitis, diarrhea, that were really where our focus lied.
And so certainly with the immunosuppression medications, have you seen in other patients effects on the livers with COVID-19 infection?
Yeah, so that's been interesting because it's been something that we've been looking for and evaluating for, so being on immunosuppressant medications would put you in that sort of high risk category, right? And I think there's been a big concern amongst our patient population, especially, what is their risk of contracting this disease? Are they going to be impacted more severely than a lot of, patients who, otherwise would contract this illness? I would say, that what we are sort of seeing again, I think, in the pediatric world, there does seem to be a sort of protective effect just with age alone, so to speak. I don't know that we've seen an absorbent or disproportionate amount of our immunosuppressed patients that have been afflicted with this. And there's also sort of this argument that the disease seems to be a little bit like a two-phase sort of process. And so a lot of people, are sort of suggesting that perhaps even being on immunosuppression could offer protective effects. And what I sort of mean by that is for those patients that seem to develop more severe disease, it does seem to be from this what we call, SIRS or cytokine sort of storm or inflammation that sort of impacts the body and takes over and impacts things like the lungs, the kidneys, and whatnot. So the idea is that perhaps because of the immunosuppression, there might be a little bit of a protective effect in some of our patients. I don't know that to be true or not. That's one of the things that we're sort of looking for and discussing. But I think, even in the patient I'd mentioned beforehand, one of the things that may have prevented her from becoming really severely impacted or compromised might have been the medications that she was receiving at the time.
That's really interesting. Can you tell us a little bit about how the patients are recovering and how their recoveries are going?
Yeah, so absolutely. So, like I mentioned, I think that again, being on these different medications that impact your immune system probably means that they're going to take a little bit longer to sort of get rid of that virus or shed that virus, right? I think we're still learning a lot more about testing and what that means, and if having a positive PCR weeks after your symptoms have resolved, is that still significant or not? So in the patients that we've seen, I can say that, they're recovering very nicely. Our transplant patient is doing well. She's happy. She's smiling every time that we see her. Her diarrhea has gone away. The liver, as you can imagine, following her liver tests has been a little bit tricky to interpret what those mean in trying to balance, her risk for rejection with, really respecting this infection and virus. But overall, she's doing quite well, and her numbers have gotten much, much better since the beginning.
Well, that's certainly great to hear. That's encouraging for sure.
Uh-huh.
You mentioned that kind of the work of the hospital and taking care of patients with chronic liver disease is still ongoing and really important, especially during this time. We're wondering what kind of strategies have been effective to continuing this ongoing care, especially for children with autoimmune liver disease and other chronic disease.
Mm-hmm. So I think one of the things that, we sort of learned about or recognized pretty quickly was really reinforcing the idea of social distancing and sheltering at home. And I have to believe that really was one of the strategies that probably helped the most. And so really what we did back in early March was really looking at, our schedules, people who were scheduled to come into the office for visits, and we had to decide whether or not that was really warranted and worth that risk. And I think in most situations, we canceled appointments pretty quickly. We were pretty quick to limit, only to those patients that absolutely needed to be seen. Around this time, I will say our institution had actually switched our medical record system, and I think that actually helped facilitate the idea of televisits and virtual visits, right, as a way to communicate and keep an eye on patients and do check-ins. One of the things that we also had struggled with at the beginning, was the idea of licensing and malpractice. So as you can imagine, here in New York City, we do care for a number of patients that live outside the state, and even though they may be just a car ride away, 10, 20 minutes at times, minus traffic. It was a little bit of a barrier that we weren't allowed to do virtual visits with those patients because they were technically sitting in another state. Well, those requirements were quickly waived by New York, and which was quite helpful. And so really the idea of keeping people at home, having the opportunity to check in with them whenever we need it. It's quite easy to schedule a virtual visit, right? If you don't have to worry about clinic space and other things like that. And so really deciding, how they were doing, if there was something going on that couldn't be managed over the phone, if they absolutely needed an office visit, we could help facilitate that. I think another strategy was the idea of, is maybe you're due for blood work, but is it really necessary at this time? And so I think, we had to reevaluate what, routine lab work sort of meant, right? And I think in many situations we decided that, you know, if people were doing well, we weren't making any changes to their medication, we were going to kind of reassess each week as things were sort of changing and developing. And so for the most part, we kept them at home. We weren't sending people, you know, for labs just because it was sort of time. And I think those were very helpful strategies.
That's great. I know that you also have a clinic to help young adults transition to an adult hepatology team. How are you helping the patients and their families navigate this transition during the pandemic when, you know, there's a little bit less access to clinic visits?
Yeah, so again, I think this is almost in some ways an opportunity to reach a lot of these patients, you know, so again, I think our no-show rate is a little bit lower, I would say, right? And so more people, I think, are sort of welcoming the distraction, even if it's just a doctor's visit right now. And so it really is a way to kind of focus on what's been going on with our patients, to connect with them. I've been really using it as an opportunity for education, right? And so sometimes, you know, in the office, it's hard because people may be distracted on the phone or things like that. Now I am the phone, right? So they're looking at my screen, and we really take the time to go through things like, you know, the underlying disease. What is it that you come and see a hepatologist for, right? We make sure that that's clear. It's an opportunity to really focus on what medications that they're taking. Do they understand, you know, what those are being used for? What are the risks if they don't take them? What are the doses? What are the times that they should be taking them? What happens if they're late? So I think this has really been, you know, a nice opportunity for us to focus on things like that. You know, when you don't have to worry about performing a physical exam, you know, it frees up a lot of time in your visit. And you know, I think so the educational part is one thing that we've been focused on. The other part is that, you know, especially in some of our adolescent and young adult patients, that's a difficult age and it's a difficult transition time. And that's why we have this platinum program, so to speak. And so for us, it's always something that we've been very mindful is their psychosocial well-being. And what we have actually been able to do just in the last few months was we hired a psychologist who is, you know, is familiar with transplant patients, not just liver, but all transplant patients, and has had experience working with this young adult group. That we sort of have an idea of which are our high-risk patients, who are some that might be struggling, especially during these times. And again, through the use of televisits, we've been able to have her reach out to those patients and to initiate, you know, therapies. And again, everyone seems to sort of have a little bit more free time on their hands these days if they're, you know, really practicing social distancing and staying at home. They're not essential workers. And so that's been one of the things that we've really been able to sort of focus on and reach out to our patients and services to offer them.
It's great to hear that you've still been able to maintain contact and relationships with patients, help them during this time, and also really provide the psychosocial and psychological support and therapies that are so necessary, especially during this time.
Yeah.
So how are the patients that you're seeing coping and handling the effects of the pandemic?
Mm-hmm. Yeah, so I think some of that is probably a little bit age dependent, and also, you know, it sort of depends on what type of support that they have at home. So, you know, some of my younger patients, for instance, I talked to like a 6-year-old the other day with autoimmune hepatitis. And I think most of our visit was her been telling me about how many new movies she had been watching. I think some of the, you know, screen time has been relaxed in a lot of homes. And so that was her way of coping, so to speak. You know, she mentioned missing things like cheerleading and seeing her friends, but I think, you know, had a few sort of Zoom sessions, kind of like we're doing right now, with her coach, with her teammates, you know, that was really, she was enjoying. I think for, you know, some of our older patients that are a little bit more aware of what's going on and what this all sort of means, you know, being at home and being distanced has certainly been hard. And I think it's, you know, we're trying, that's why we're really trying to be able to reach out to them with whatever resources we may have, encouraging, you know, mindfulness, just focusing on yourself, whatever that means, exercise, eating right, taking your medications, you know, things like that. So it's been difficult for sure. But I think everyone is kind of finding their own way to make use of their time at home and to get by.
It's great that you're able to provide the support for patients during this time too. So how are you promoting and maintaining your own health and mental health while working as a physician?
Yeah, so that's a great question. I think that, that's something that we've all had to kind of explore recently, right? And I think some, different things work for different people. I think for me, what I found and what I know about myself that's worked in the past is really routine. So trying to, even in days when I may not be rounding in the hospital like I am this week, trying to just keep my routine as best as I can, scheduling meetings, patient visits, things like that, check-ins with our team. Exercise really helps me. So I make sure that no matter what or how I'm feeling, I've got at least an hour a day that I set aside for that. It may not be going to the gym like I normally would, but I think, again, people have gotten really creative and there are a lot of online classes. I know my gym offers like online classes throughout the day that you can watch and participate in. I got a Peloton, so I'm finding like different ways to do that. But that's been really helpful. And, I think this has also been an opportunity in some ways to reconnect with like old friends, people checking in, just wondering how it is, from someone in the healthcare field, and seeing what my experiences are, making sure I'm okay, really appreciating the fact that people are asking if there's things that they can do or ways they can support me. And honestly, it's really just those check-ins that really help, I think, the most. And I've been really kind of like an emotional boost, so to speak. So I've really enjoyed that.
Good. Well, I'm glad to hear that you're doing well and that you're able to kind of keep some routine going on. And I know that the patients and families that you care for are really appreciative for the time and you being there with them during this time. Mm-hmm. I was wondering, can you share any experiences or stories that have brought you hope during this time?
Mm-hmm. Yeah, so there probably are a lot of things. And I think one thing about this situation, it makes you a little bit more aware and appreciative of a lot of those things you're sort of alluding to. I don't know how many people are familiar with the 7 o'clock clap, but it's definitely something that has gained quite a bit of attention here in New York City. And I think it's something that happens at 7 p.m. every day. It sort of correlates with the change of shift at the hospital, so to speak. And it's not just for healthcare workers, but for all essential workers, out there. So people that are running our public transportation system, deliveries, restaurants that are, still open and trying to make sure that, people are still well fed through all of this. And I will say it started, probably over a month ago now. It was something that would, if you kind of strained, you could hear a few claps in the evening. Now it's really gained a lot of momentum. And so come 7 p.m., no matter where you are, you can almost most certainly hear people hanging out of their apartment windows, clapping, banging on pots and pans. I think there's been a resurgence in the New York by Frank Sinatra that people are blasting from speakers. And so, it really is something that I think is just unbelievable in a way that people can really show their appreciation and support. Just earlier this week, I was walking home and I happened to be wearing, scrubs, and it was right at the 7 o'clock mark. And as I was walking by, I was also stopped by she probably couldn't have been more than 5. And, it took me a moment to sort of understand that she was, yelling at me and just saying, hey, thank you, doctor. We love you, doctor. And so that was kind of like an emotional high and really, gives you a sense of like why you're here, why you're doing this. And so I think that's something that's been quite incredible.
Good. Well, I'm glad that in the midst of it all, the community is really pulling together, both within the hospital and the New York City community as a larger group. Thank you so much for your time, for talking with us today, for sharing your experiences. Thank you for taking the time out of your busy schedule, especially knowing that you are actively in the hospital working too. We just really appreciate you and all that you're doing.
Absolutely. Thank you so much for having me. I really appreciate it and allowing me this opportunity to share with you our experiences.
It's great to see you. Thank you again.
Mm-hmm.
Thank you all for being with us, and special thanks again to our doctors in a hot zone, Drs. Chaco and Vittorio, as well as our moderators, Dr. Taylor and Aaron Anderson. The insight we gained from our guests today was truly heartening. I think it also made clear the challenges during this pandemic are universal, but there are so many instances where people are adapting and overcoming. Even more stories like these to come in our next webinar when we focus on the patients that have been weathering the storm as well. Thank you for joining us.